Hello everyone and welcome to one of the very interesting lectures that everyone is waiting for. Today we are discussing the approach to wide complex tachycardia, and I know this is one of the very difficult topics in ECG, but also it is one of the very interesting topic, as we are going to learn today the differential diagnosis of wide complex tachycardia and how to use Brugada criteria and Vereckei algorithm to differentiate VT from SVT with apparency. First of all, we know of course that the differential diagnosis of tachycardia in general, that we divide them into narrow-complex tachycardia and wide-complex tachycardia, and each one of them is subdivided into regular and irregular. So in wide-complex tachycardia we have regular wide-complex tachycardia and irregular wide-complex tachycardia. First, of course, the regular wide-complex tachycardia is divided into ventricular tachycardia, SVT with apparency, and antidromic AVRT. Whereas the irregular wide complex tachycardia is subdivided into pre-excited AF and polymorphic VT, and of course AF with apparency. And of course we need to ask ourselves before going in depth in the wide complex tachycardia, are there any other possibilities for wide complex tachycardias apart from these examples? Yes, of course. We can have SVT in patients on antiarrhythmic medications, and in this case, the antiarrhythmic medication as class 1A and class 1C, as they are sodium channel blockers, would prolong complex duration. So SVT in those patients may present as wide complex tachycardia. Also in patients with pacemaker-mediated tachycardia, which is a specific type of tachycardia that would be discussed later. In this case, the patient has wide complex tachycardia, and these wide complexes represent paced complexes, so it's considered wide complex tachycardia. Electrolyte disorders, especially hyperkalemia, of course, could present with wide complex tachycardia, although the heart rate would not be very high in hyperkalemia, but in case sine wave pattern you may be mistaken that this is ventricular tachycardia and is actually hyperkalemia. And in case of artifacts in ECG, it may present in the form of wide complex tachycardia, and in many cases the artifacts caused, for example, by tremors or any vibrations would present in this form, and actually it is not any wide complex tachycardia, it's just artifact. For example, here, when we see this ECG, I would assume that this patient has non-sustained ventricular tachycardia, but actually this is not ventricular tachycardia. We can see well-defined complexes in between these wide waves, and so these are complex and these wide waves are just artifacts in the ECG. So just try to concentrate whether the wide complex tachycardia is actually tachycardia and is tachyarrhythmia, or these are just artifacts. Of course, we know that the mechanisms of tachyarrhythmia, as we learned before, can be caused by re-entry, triggered activity, either early or delayed after depolarization, and automaticity, either enhanced as an SA node or abnormal in other sites. Today we are going to focus on regular wide complex tachycardia, and irregular wide complex tachycardia would be discussed in a separate lecture. So of course we know that the differential diagnosis of regular wide complex tachycardia is ventricular tachycardia, SVT with apparency, and antidromic AVRT. Let's start with VT. If we need to classify VT, we can classify it according to the mechanism into reentrant VT, can be triggered VT caused by after depolarization, and in some cases it can be caused by abnormal automaticity, so it is automatic VT. Reentrant VT can be caused by scar-related VT, which occurs in patients with already structural heart disease and they have multiple scars in the myocardium, and so these scars can develop a scar-related reentry. As we know that reentry needs an obstacle in the middle and two pathways around it with different conduction velocity and different refractory periods, and this gives a substrate for development of a reentrant circuit. Fascicular VT, which is a very common type of ventricular tachycardia in middle-aged or young males, and bundle branch reentrant VT. In case of triggered VT, it can be caused by idiopathic VT, which is a type of VT that occurs in patients with structurally normal heart, and it is considered to be an aggressive form of idiopathic VVCs that sustains themselves into ventricular tachycardia. Digoxin toxicity, because of the increased intracellular calcium, can cause delayed after depolarization, leading to triggered VT. Catecholaminergic polymorphic VT, which is a form of a channelopathy caused by increased concentration of intracellular calcium, leading to delayed after depolarization. Long QT syndrome can lead to early after depolarization because of the increase in the transmural dispersion of repolarization, and in case of ischemic injury or reperfusion injury in acute MI, it can lead to triggered activity because of the abnormal calcium handling. Ischemic injury and reperfusion injury also can lead to VT by another mechanism, which is the abnormal automaticity. So ischemic injury and reperfusion injury can lead to ventricular tachycardia either by triggered activity or abnormal automaticity. SVT, of course, we know the three famous subtypes of SVT, which are AVNRT, AVRT, and atrial tachycardia. But in this case, the SVT was associated with bundle branch block apparency, and so it presented as Y-complex tachycardia rather than NAR-complex tachycardia. What can cause bundle branch block apparency? It can be pre-existing. This means that the patient already has sinus rhythm with resting left bundle or right bundle branch block. And so, of course, when he develops SVT, it would not have NAR complex because already the patient has Y complex before development of SVT. So he has SVT with apparency and it is caused by pre-existing bundle branch block. And so resting ECG shows the same apparency in sinus rhythm as in SVT. But in some cases it can be rate dependent. This means that with increase or marked increase in heart rate, the bundle branch block may not have enough time to recover from refractoriness, and so the SVT develops rate dependent bundle branch block, either left or right. And in this case, the difference that resting ECG is normal, it doesn't show any bundle branch block, but in SVT it shows wide complex. And of course we know that right bundle branch block apparency is more common than left bundle branch block, and we discussed this issue in the lecture of ectopics in ECG, as we learned that right bundle branch block has longer refractory periods than left bundle branch block. Antidromic AVRT, of course, we remember when we discussed the AVRT, we mentioned that it has two subtypes. Orthodromic AVRT, in which the anterograde conduction was inside through the AV node and then retrograde through the accessory pathway, and because the conduction passed in the hyperconjugal system, it showed narrow complex. In this case, in wide complex or antidromic AVRT, the antegrade is through accessory pathway and then retrograde through AV node, and so it presents with wide complex tachycardia. It is a less common presentation of AVRT, as orthodromic is much more common, but of course it lies in the differential diagnosis of wide complex tachycardia, because it is not uncommon to see antidromic AVRT in patients with manifest pre-excitation or Wolff-Parkinson-White syndrome. So in the ER, what you would see is wide complex tachycardia. I just see wide complex tachycardia. Sometimes it is difficult to differentiate whether it is ventricular tachycardia, SVT with apparency, or antidromic AVRT. And that's why there are a lot of algorithms since 1965 in order to learn you how or teach you how to differentiate VT from SVT's apparency. And so of course it is very difficult to learn all these algorithms. And so today we are focusing on important features that are very common to be used in order to help you. Brugada criteria, Vereckei criteria, or sometimes pronounced as Vereckei criteria, and other specific assisting criteria in differentiating VT from SVT with apparency. And I think the next part is the most interesting part in our lecture today. Let's start with Brugada criteria. Brugada criteria is the first one of the Brugada criteria is to detect whether there is an absence of RS complex in all precordial leads. If the answer is yes, it is VT with nearly 100% specificity. But if the answer is no, so move to the second criterion, which is the duration from the onset of R to the nadir of S interval is more than 100 milliseconds in just one precordial lead. If you apply this criterion in just one precordial lead, so it is VT. But if it is not applied, so we move to the third criterion to search for AV dissociation, fusion beat, or capture beat. Presence of any of these features means that there are two rhythms inside the heart, and so it suggests ventricular tachycardia. But if the answer is no, move to the last criterion, which are the morphology criteria for VT in the chest lead, whether it shows typical or atypical bundle branch block. If it shows atypical morphology, it is VT. If it doesn't show any atypical morphology, it is just the typical left bundle or typical right bundle, it is SVT. Of course, these criteria are very famous, but of course many of us don't remember or don't understand why are these criteria applicable, and why when the answer is yes it is VT and the answer is no it may be SVT. So this is what we are going to do today. Let's explain the first criterion, which in this ECG example, we could say that there is complete absence of any positive wave in precordial leads. So all the precordial leads show completely negative complex, not just predominantly negative. No, there is no any evidence of any small positive R wave in these complex, and so we call this sign negative concordance. Negative concordance means that all precordial leads show QS pattern, so there is no R waves in this lead, and this feature is 100% specific for VT, and so we consider that negative concordance, which is the first ECG feature in the Brugada algorithm, is to be 100% suggestive of ventricular tachycardia. Let's move now to the second criterion, which is the onset of R to nadir of S. Here, if the duration from the onset of R to the nadir of S is more than 100 milliseconds in one precordial lead, it is suggestive of ventricular tachycardia. But what do we mean by this? If this is the example here, we can say that we calculate the duration from the onset of the R wave to the nadir, which is the bottom of the S wave, not the end of S wave. And if it is more than 100 milliseconds in this case, I would suggest that this is ventricular tachycardia, and this is 98% specific. But what is the explanation for this? Why the duration of this interval is more than 100 milliseconds? In this case, I would consider it VT. Because conduction in VT starts initially in the ventricular muscles, the ventricular muscle conduction is relatively slower than in his Purkinje system. And so here, the initial part of the complex is wider than in SVT's apparency. So when we find that the initial part of the complex is much wider, and here the limits for this interval is from the onset of R to the nadir of S is more than 100 milliseconds. In this case, I would consider that this is suggestive for VT. So in this ECG example, if I would calculate from the start of the R to the nadir of S, and it is more than 100 milliseconds, it is suggestive of ventricular tachycardia. Let's move now to the third criterion. Here, of course, we remember in third degree AV block, which was discussed in the lectures of AV block, the blocked conduction between the atrium and the ventricles lead to something called complete AV dissociation. What was meant by complete AV dissociation? We explained that dissociation means that the atrium and ventricle are electrically dissociated from each other, and so the atrial rhythm represented by the P waves is completely dissociated from the ventricular rhythm represented by complexes due to the blocked conduction between AV nodes. In this example here in VT, there is a separate focus in the atrium, which is mostly the SA nodes, and a separate focus in the ventricle, as in example, for example, reentrant circuit or an automatic focus in the ventricle, leading to a ventricular rhythm which is very rapid dissociated from the atrial rhythm, which is mostly the SA node. And so ventricular tachycardia leads to a form of complete AV dissociation. There is dissociation between the sinus rhythm and the ventricular rhythm, and so you cannot find a consistent one-to-one AV relationship in the ECG. So presence of dissociation in the ECG is a strong feature suggestive of presence of two distinct rhythms in the heart, and so it is suggestive of VT rather than SVT with apparency. If we move here to another criterion, we move to another criterion, which is a fusion beat. Fusion beat means that a supraventricular beat and ventricular beat coincide to each other to produce a hybrid complex showing bizarre morphology, indicating presence of two foci firing simultaneously. And so fusion beat is just a fusion between two beats, a supraventricular beat and a ventricular beat. Whereas capture beat means that instead of presence of a ventricular beat firing at the time, it was completely supraventricular impulse taking the upper hand in one cycle, leading to intermittent return of atrial control within the tachycardia. And so I find that there is one narrow beat inside the wide complex rhythm suggestive of a capture beat. So fusion beat is just a fusion between two beats, supraventricular and ventricular beat, and capture beat means that there is a completely supraventricular beat inside the ventricular rhythm. And so these two features represent presence of two distinct rhythms inside the heart. So in this example here, we can find, for example, that the patient has a capture beat. There is a narrow beat within the tachycardia, and so this is a capture beat. Here in this example, we can find that there are distinct P waves, sometimes on the top of the T wave or at the end of the T wave, and they are dissociated from the complex. We can find here a capture beat, and so these features are representative of two distinct rhythms. And of course here we can find another fusion beat, which represent different morphology due to the fusion of two distinct rhythms. and presence of one of these features is 98% specific for ventricular tachycardia. So these features or presence of these features are suggestive of ventricular tachycardia because they indicate presence of two independent rhythms inside the heart. Then let's move to the fourth criterion, which I know that it may be vague for many of us, but I would explain it in here in order to understand what is the typical morphology and the atypical morphology. Of course, we know that the morphological criteria for the VT in precordial leads are atypical. In SVT with apparency, of course, despite apparency, still the conduction is through the His-Purkinje system, and so left bundle or right bundle branch block apparency would show typical morphology because the conduction disturbance is within the His-Purkinje system. Whereas in ventricular tachycardia, left bundle or right bundle branch block would show atypical morphology because the conduction starts within the ventricular muscle fibers, not within the His-Purkinje system. And so I would not expect the typical left or right bundle morphology that we explained before in the lecture of bundle branch blocks. So this is the core difference in differentiating VT from SVT with apparency is the complex morphology or the bundle branch block morphology. So let's give an example here. Let's start with right bundle branch block. In SVT with apparency, I would expect to see the typical RSR- pattern, which is the typical right bundle branch block morphology, and we understand why we would see this morphology, and I would put a link here to the lecture of bundle branch blocks in order that if anyone wants to revise what was the explanation of these bundle branch block morphologies. But here in V6, of course, it shows completely the opposite. It shows QRS pattern, and usually RS ratio is more than 1. We can find here that the RS ratio is more than 1 because the amplitude of R wave is more than the amplitude of S wave because the complex is predominantly positive. And then in VT, because of the atypical morphology, I can see many atypical variants. For example, I could see monophasic R wave, I could see QR pattern with a small q followed by a long R wave, I could find RS pattern long R followed by the small S wave, and sometimes I could see a pattern of RSR- but with a reversal. Sometimes we call it rapid ear sign. And in case of V6, I could find here an example of RS wave with an RS ratio less than 1, and sometimes I could find QS pattern in V6. Of course, it's difficult to put in your mind all these morphological variants, but just put in your mind that if you see atypical morphology for right bundle branch block, this may suggest right bundle branch block. Then we can move to the left bundle branch block. Here in case of SVT with left bundle apparency, I could see here that the typical morphology is that I may find small R wave in the start of V1, and then I find a deep S wave with a fast descent. And in V6, of course, I would see monophasic R wave or notch R wave, but we remember all of us that the first sign of left bundle branch block is absence of initial Q in the chest V in lateral leads. Here, in case of the atypical morphology, I would see the same morphology of RS pattern, but I would expect broader R wave, slower descent of the S wave, and sometimes I may find a notch in the descending limb of S wave. And we explained before that the initial part of the complex in the VT is much slower because the conduction is passing through the ventricular muscle fiber rather than the His-Purkinje system. And in V6, I would see the same morphology of the R wave, but it could be preceded by an initial broad Q wave, and so this is against the typical morphology of left bundle in which the septal depolarization should disappear. And so here I would expect initial Q in V6, explaining that this is atypical morphology. So whenever you see atypical morphology for left bundle branch block, I would expect that this is most probably ventricular tachycardia. It is not a must, but it may be very suggestive of VT. Of course, there is another terminology called the Kindwall criteria of left bundle branch block, which focus on that time interval. If the initial part of R wave in V1 or V2 is more than 30 milliseconds, or the interval from the onset of R to the nadir of S is more than 60 milliseconds at the time it is suggestive of VT, if we find notched downstroke of the S wave, of course it is suggestive of VT, and if I find initial Q in V6, or I find completely QS wave or QR pattern, so any Q wave in V6 at the time, these are suggestive of left bundle branch block caused by VT rather than than SVT with apparency. And so presence of these features are called Kindwall criteria of left bundle branch block in VT, and they are suggestive of ventricular tachycardia because they represent atypical morphologies. And here, whenever the time interval is longer, this is much more suggestive for ventricular tachycardia. There is another sign in the VT called Josephson sign, which is notching in the downstroke of the S wave near to the nadir of S wave. And there is another thing called the Brugada sign, which is a distance from the onset of the QRS complex to the nadir of S wave is more than 100 milliseconds. It is nearly the same as the second criterion, and if it is more than 100 milliseconds at the time, we consider it suggestive of ventricular tachycardia. So this is Josephson sign, and this is Brugada sign. And so Brugada sign is nearly the same as criterion number 2 in the Brugada algorithm. What is meant by rapid ear sign? Rapid ear sign means that the R wave is taller than the R dash wave. So in typical morphology, initial R is shorter and narrower than R dash wave, and this is the typical right bundle branch block, whereas here initial R wave is taller than the R dash wave, and there is a notch on the downslope, so it is atypical morphology. So rapid ear sign means the reversal of the typical right bundle branch block morphology. So remember, any atypical bundle branch block morphology in wide complex tachycardia should raise suspicion for VT rather than SVT with apparency, and this is almost 98% specific for VT. So instead of putting in your mind all these atypical morphological variants, just atypical morphology should raise suspicion for VT. And so I need to ask a question that we need to ask ourselves, because of course one of the very famous quizzes is to ask, when does the VT show typical right bundle branch block? The answer of course is very famous. It is fascicular VT. Fascicular VT, as we can see here, that fascicular VT shows typical right bundle branch block morphology, and we can see the axis is coming towards the left side. So what is fascicular VT? Fascicular VT is a specific type of VT that occurs in structure in normal heart, especially in middle age or young males. We have of course the anterior fascicle and the posterior fascicle. Here there is something called area of slow conduction or verapamil sensitive zone, in which the antegrade conduction passes through it, and then retrograde commonly through the posterior fascicle, forming a reentrant circuit consisting of these two limbs. And so because this circuit is inside the left ventricle, it shows right bundle branch block, and it is typical right bundle branch block because it is still within the Hesper-Purkinje system, and of course the axis of the heart here, it would be directed towards the left-sided leads, and so it is left axis deviation, so it would show positive complex in lateral leads and negative complex in inferior leads with typical right bundle branch block morphology. So fascicular VT is a reentrant mechanism. It occurs in structure in normal heart. It is more common in young males. It shows typical right bundle branch block morphology because it originates from the left ventricle, and it involves the Hesper-Purkinje system, relatively narrower than the classic pattern of VT. That makes sense because it is inside the Hesper-Purkinje system. Posterior fascicle is involved in 95% of cases, and in 5% or less than 5% it involves the anterior fascicle, and so commonly it shows left axis deviation, and it is sensitive to calcium channel blockers. So this is one of the specific types of VT that can be terminated by IV calcium channel blocker, and of course it is amenable for ablation. And the next question, when does the VT show typical left bundle branch block? It can occur in bundle branch reentrant tachycardia. What is meant by this? It is also a specific type of VT that occurs in patients with structural heart disease, especially dilated cardiomyopathy. Here, the antegrade limb is commonly the right bundle, and then the retrograde limb is commonly the left bundle, though vice versa is not impossible, it can occur. And so here, the reentrant circuit is formed by two limbs, the right bundle branch and the left bundle branch. And because the antegrade limb is right bundle, so the morphology is typical left bundle branch block morphology. So bundle branch reentrant, from its name, it is a reentrant mechanism, more common in patients with ischemic LV dysfunction or dilated cardiomyopathy, especially those with Hesper-Purkinje system conduction delay. It is more common to involve the right bundle as the antegrade limb and left bundle as the retrograde limb, resulting in typical left bundle branch block morphology, and vice versa would result in typical right bundle branch block, but it is less common and may degenerate into VF, and so it is one of the causes of sudden cardiac death in patients with structural heart disease, and of course it is amenable for ablation by ablating the right bundle branch. So remember, of course, that Brugada criteria, although they may be useful for differentiating VT from SVT with apparency, they are not useful in differentiating between VT and antidromic AVRT. And so in order to recognize that this wide complex tachycardia is antidromic AVRT, you would depend on the resting ECG pattern, which would show manifest pre-excitation. So when the patient has antidromic tachycardia, it may be difficult from the start to recognize that this is antidromic. You may say it is VT, but when you terminate this tachycardia and detect the resting ECG, because as we mentioned before, that you should record the ECG during tachycardia and after termination, I would find features of manifest pre-excitation or Wolff-Parkinson-White syndrome like short PR, delta wave and wide complex, and so I would suggest retrogradely that this wide complex tachycardia was antidromic AVRT. Let's move now to the Vereckei criteria. Vereckei criteria depends on criteria especially in AVR leads, so we focus here on AVR. Presence of initial dominant R wave in AVR, if the answer is yes, is suggestive of VT, and if the answer is no, move to the second criterion. Presence of initial R wave or Q wave more than 40 milliseconds in AVR, it's suggestive of VT, if the answer is no. Notch down stroke of a negative complex, of the answer is yes, it's VT, of the answer is positive, I detect what's called VI-VT ratio, if it is less than 1, yes, VT, no, SVT. Of course, it is very vague, so let's explain each one of them. Start with the first criterion. Presence of an initial dominant R wave. Here, I mean that AVR is predominantly positive. I may find dominant R wave, there may be small Q wave like Q or R wave, but if there is an initial dominant R wave, this means that the axis of the heart is towards the right upper quadrant. So of course it is an extreme axis deviation, which is rarely to occur with SVT with apparency. And so if AVR looks like this feature at the time, I would consider it to be VT as the most probable diagnosis. The second criterion is that initial R wave, if it is more than 40 milliseconds, in this case I would consider that this is VT most probably. And if there is initial Q wave more than 40 milliseconds, of course I would consider that this is most probably VT. Then, if there is notch down stroke of a negative complex, this would suggest slower conduction, and so the initial part of the complex is wider and showing notch, so this is suggestive of VT. The last criterion is the VI-VT ratio. VI means the voltage change in the initial 40 milliseconds, and VT means the voltage change in the terminal 40 milliseconds. And so I would calculate in the first millisecond the voltage difference, and in the terminal 40 milliseconds the voltage difference. And if VI on VT is less than 1, this means that the initial part of the complex is slower than the terminal part of the complex, so of course it makes sense that this is suggestive of VT. I know of course it may be difficult to be calculated and it needs like a ruler and paper in order to calculate it, but it's just that if the initial part of the complex is slower at that time, it is suggestive of ventricular tachycardia. So these criteria of course depend on the notion of extreme axis deviation in VT and slowed conduction, and they only look at the AVR. Move to the assisting criteria. For example, we remember that we mentioned that negative concordance, which are entirely negative complex in all precordial leads, so absence of any RS complex in chest lead is very suggestive and specific for VT, and is the first criterion of Brugada algorithm, and it suggests that the VT originates from the LV apex. So here, for example, this is called negative concordance. Then positive concordance, which is the opposite to the negative concordance. It means that there are entirely positive complexes in all precordial leads, so there are absence of any Q wave or S wave in the chest leads. So this is suggestive of VT, but it may suggest antidromic AVRT using left-sided accessory pathway, and so all the complexes in the chest lead are showing like atypical right bundle branch block, and they are all positive. So positive concordance may suggest VT versus antidromic AVRT. So this is an example here of entirely positive complex in all chest leads. If left bundle is more than 160 milliseconds or right bundle is more than 140 milliseconds, these criteria are suggestive of VT, and they raise the notion that the wider the complex in wide complex tachycardia, the slower the conduction velocity, and so the higher the possibility of VT. So the longer the duration, the more possibility this wide complex is VT. And regarding the axis, if there is extreme axis deviation, this means that the axis is directed towards the right upper quadrant between -90 degree to 100 180 degrees. This is suggestive of extreme axis deviation, or axis shift inside the tachycardia is more than 40 degrees difference from the baseline ECG in sinus rhythm, but is less specific. These features are suggestive of VT. So extreme axis deviation, which was represented by the predominantly R wave or dominant R wave in AVR in the Vereckei algorithm, this is very suggestive of ventricular tachycardia. There is something called PAVA criteria. It depends on something called the intrinsic deflection time, which is R wave peak time. If I calculate the time interval from the start of the R wave to the peak of the R wave, which is called R wave peak time in lead 2, in this case, from the complex onset to the first change in polarity is more than 50 milliseconds. It is very sensitive for detection of VT because of the slower conduction in the initial part of the complex. So here I calculate from the onset of the complex to the first change in the polarity, not just in the R wave, but just in change in polarity. If it is more than 50 milliseconds, this is sensitive and suggestive of ventricular tachycardia because of the slower conduction. So R wave peak time represents the time taken from excitation to spread from endocardial surface to the epicardial surface of the LV. Of course, ECG criteria are very important to differentiate, but are the ECG criteria always conclusive in determining the cause of wide complex tachycardia? Of course, the answer is not. Unfortunately, the answer is not. They are not useful in the following case. Antidromic AVRT, of course, we mentioned that Vereckei and Brugada algorithm are not helpful to detect antidromic AVRT, and here there is a good solution. So just look at the ECG on the resting state, which would show presence of manifest pre-excitation. Fascicular VT, of course, it shows typical right bundle branch block morphology, and so, of course, you may be mistaken that this is SVT with right bundle branch block because it shows typical right bundle branch block morphology. But whenever you see SVT with typical right bundle branch block morphology, suspect fascicular VT, not just SVT with right bundle branch block apparency. Bundle branch reentrant tachycardia, it is the same, because here I would see typical left bundle branch block in most of the cases, and so I would misdiagnose it as SVT with left bundle. But the answer is that this patient has pre-existing structural heart disease, and so I would suggest VT rather than SVT because the patient already has structural heart disease. VT with exit site close to the Hesperkinch system may show typical bundle branch block morphology, and so it is difficult to differentiate. And why complex tachycardia occurring in a patient on antiarrhythmic drug therapy like class 1C, which prolong complex duration, may of course make a misdiagnosis regarding that this is VT or SVT with apparency. It would be very difficult. Of course, I know that this is the expression of most of you who of course may get confused when we use these criteria or try to explain them. And so the answer is easy. To achieve a high positive predictive value of more than 95% to identify VT, you should combine 3 clinical criteria at least. And here, of course, we mention more than 2 clinical criteria. We mentioned the Brugada criteria, the Vereckei, and the assisting criteria. So don't just depend on one criterion in order to detect that this is VT or this is SVT with apparency. Try to use more than clinical criteria. Of course, AV dissociation detected clinically through neck vein examination, in which I would say Cannon A waves, because sometimes the atrium may contract against closed tricuspid valve, so it would lead to Cannon A waves on the neck veins. Of course, it is very suggestive of AV dissociation. Even if you cannot detect it in ECG, it is clinically visible, and so this suggests VT. Of course, check for past history of heart disease is very important because, of course, there is a notion that why complex tachycardia in a patient with heart disease. Of course, it is very suggestive of VT as the first possibility because in patient with structural heart disease, VT is much more common than SVT with apparency. And sometimes adenosine or carotid sinus massage may help to differentiate. And here, in this example, VT versus SVT with apparency, if I give adenosine or carotid sinus massage, if there is slowing down or transient pause of the sinus rhythm without affecting the ventricular rate, so this is mostly VT, whereas here I may say sudden termination of the tachycardia or no effect. So adenosine or carotid sinus massage may help to differentiate VT from SVT with apparency in difficult cases. And of course, at the end of our lecture, remember this quote: why complex tachycardia is VT until proved otherwise. So don't confuse yourself when you cannot use these criteria, especially that most of the cases you would see VT in the ER or in a patient in your CCU or ICU, and so you need a clinical quick decision. So why complex tachycardia is VT until proved otherwise is always the case, because if you misdiagnosed SVT's apparently as VT and you treated it as VT, the patient is not harmed and he would result in termination of the wide complex tachycardia and restoration of sinus rhythm without any harm. But if you misdiagnosed VT as SVT's apparently, the patient may develop hemodynamic collapse, because if the blood pressure was sustained at the time, you may give him IV verapamil or beta blocker, and if he has structural heart disease like LV dysfunction, he may develop hemodynamic instability. And so if you get confused, please don't be overconfident in saying that this is SVT's apparently or this is VT. No, just use this complex if you are confused. Why complex tachycardia is VT until proved otherwise. And remember, of course, why complex tachycardia in a patient with history of heart disease is very, very strong evidence of VT as a first possibility. Regarding irregular white complex, because of course today we discussed a lot of information, so I choose to discuss the irregular white complex tachycardia in a separate lecture, which would be the next lecture. So at the end, we understand today the differential diagnosis of white complex tachycardia. We understand how to use Brugada and Vereckei criteria to differentiate VT from SVT's apparently, and we learned today how to make a clinical decision for a patient presenting with white complex tachycardia to make a quick decision whether I would manage it as VT or SVT's apparently. And always remember our take-home message: white complex tachycardia is VT until proved otherwise. Don't depend on one criterion to differentiate. Use many criteria, at least 3 criteria to differentiate, and all ECG criteria have exception, and all of them have percentage of specificity and sensitivity, and so depend on the history and examination together with ECG to make a decision. Thank you very much for your listening.